Okay, hi guys. I did the Zoom meeting this afternoon for your review for the test for tomorrow. I did kind of figure out why I haven't been able to record them. I've been doing Zoom on my iPad, and the version I have doesn't have that available on the iPad. It's on the computer. So I just opted, my daughter helped me figure that out, but so I just opted to do a short video to cover what we talked about, so that even those that were in it can go back and look at it if they want to. So as you can see, it's pretty casual. I'm still working on your exam, so it isn't completed, but I do know the topics that I'm kind of looking at. So I am just going to kind of go over what I think you need to know. So if we go back to restraint, when you what you did last week, what you need to know is you need to know the definitions of things. So sternal recumbency, what is that? Dorsal recumbency, lateral recumbency. There was a picture of a dog, I think it was a Great Dane, that had kind of the jugular and the cephalic and the medial and lateral saphenouses outlined, those veins, so that you could see where they were. So what I will expect from you is I will either give you a Great Dane picture, that picture, and have you label them. I don't know how that's going to work in Teacherese very yet. I'm playing around with it. Or I would at least need you to know where they're located. So maybe say the cephalic, like do a matching and have cephalic vein, lateral saphenous, medial saphenous, and jugular, and they would connect to, well, the cephalic is in the front limbs, the jugular is in the neck, the lateral saphenous is on the lateral aspect of the hind leg, and the medial saphenous is on the medial aspect of the hind leg. So that you would know something like that. Or it could be something where I would ask which vessels you use for a dog and which ones you use for a cat. So I thought I'd go over that just to make sure you guys understood that, because I don't know that I hit that real hard. I remember talking about it, but jugular vessels, they can be used for dogs and cats. Cephalic can be used for dogs and cats. Medial saphenous is for cats, and lateral saphenous is for dogs. Now, when we're looking at which ones we choose to use, and I'll just give you a quick rundown because I think sometimes it helps you know, kind of even just to be able to plan on where the phlebotomist, the person drawing the blood, is going to want to go. And so the general rule is most of the time we like to go with the jugular because it's fairly easy to stick. It's a very large vessel. They tend to be okay with that unless they are head shy, and then we have to do a different plan. And once you get your needle in the vessel, it flows very, very fast, so it's a quick. The cephalics there in the front limbs, you have to hold a paw for that, which sometimes can be a little scary for them. But the big reason why we kind of avoid those is, my experience is they flow fairly slow, especially compared to the jugular. The more comfortable I have gotten with drawing blood, I like the jugulars more and more. The other reason why we keep the cephalics is we save them for IV catheters. So if this patient is going to potentially be hospitalized and need IV fluids, or if they're coming in that day for surgery, we're going to probably place an IV catheter. And we place the IV catheters in the cephalic vessel. So we don't really want to use those for blood drawing if we can help it. Even if I know like they're coming in for blood work on Monday and their surgery isn't until Thursday, I'm still going to avoid those cephalics because every time I stick them, there's scar tissue. Every time that deficit in the skin and the vessel wall heals, there's scar tissue, so it can cause scarring and it can cause issues down the road for IV catheters. So I try to avoid those. The medial saphenous is on the inner thigh of the back leg. and we use that for cats. So if I'm going to use the left medial saphenous, they're going to be in left lateral recumbency. So the leg that I'm drawing from is going to be the leg that's laying on the table because I want that inner thigh. And then if I'm going to use a saphenous vessel for a dog, I'm going to use the lateral saphenous. And I'm going to lay them, let's say I wanted to use the right lateral saphenous, they're going to be in left lateral recumbency because I need that opposite leg up in the air so that I can stick the lateral aspect. So that kind of gives you a synopsis or kind of rundown of just that Great Dane picture in a little bit more detail. So those are some things. Some other things that I might ask you, we looked at all the tools. We looked at air muzzles, hard plastic muzzles, nylon muzzles, basket muzzles, gauze muzzles, the brachycephalic muzzles, all of the muzzles, cat bag, cat gloves, the clamshell net, towels and blankets are used for kitty burrito. We have the cat bag if we don't want to use one of those. So all of those e-collar, a slip lead, you can use those. And when we looked at the e-collars, there were all sorts of different e-collars. I'm not going to get too picky about those. I'm going to hit more on the traditional ones of the muzzles and the rabies pole. Some people do refer to it as a dog catcher's pole, but the official name is rabies pole. So I will expect you to put on your test rabies pole and not dog catchers. We want to be using the correct terms with that. Cat gloves, they're just basically real heavy leather type gloves that are real thick material so their claws can't get through them very well. We can use those. The clamshell net is just that net that kind of opens up like a clam. We have them in the cat rooms at school. So any of those tools are more, I want you to know, like if I showed you a flower soft e-collar, I want you to know that it's an e-collar, but I'm not going to get too picky on their names with that. But e-collars can be used as a restraint tool. When we look at fear-free restraint, because I had to listen to that webinar, so I will ask some questions from that, and I've listened to it several times and taken notes. But things that kind of stuck out to me from that webinar is that a lot of our low stress fear-free restraint is similar to our traditional restraint. We just don't use scruff very much. We're going to be more likely to do distraction first, so we're going to bring out treats. We're going to bring out things that you smear on the wall. You're going to use, you can even use like a hard case that a syringe comes from out of and put peanut butter or sprayed cheese in that. So we'll do different techniques to distract them. And then we're real quick to use blankets, like thick blankets and fear-free. And then if we need to get to a more heavy-duty restraint, we're more than likely going to sedate. So we did talk about in your restraint lecture about the different medications that we can use for sedation. I'm not going to expect you to know like all of the details, but you should be able to recognize that if I say that we're going to use an anti-anxiety, we're going to use a tranquilizer, or we're going to use a sedative, along those lines. We've got pheromones that can help, but also with that webinar, she talked about making sure the environment's good. So that's where I just really remember, like at the end of the webinar, she showed you her cat room, and there was like an ark or a boat of some sort that she had built for that room that the cats could climb on and find hidey holes, that they could still get them out of there, but they still felt like they were hiding. So making sure our environment is good for them. So keeping our dogs and cats separate, making sure we get animals into rooms as quickly as possible, just working with the different temperaments of those animals. So that's kind of where that fear-free low stress comes in for me, is just really taking note of the environment and making sure it's as low stress as we can, keeping people calm, not getting loud, that sort of thing. But just make sure that you've watched that webinar, because that is some information we can use on the test. I would expect you to know that if I want you to draw from their right jugular and or I'm going to draw from the right jugular and I want you to restraint, you need to stand on the same side of the vessel I'm going to use for jugular venipuncture. But if I'm doing cephalic, you stand on the opposite side. So if I want the right cephalic, you're going to stand on the left side. And that's just so your body's out of the way. It's just the way it works. One thing that I kind of realized when I was doing the Zoom meeting today that I didn't show you is I didn't show you some restraint techniques for like large giant necessarily, because I have Gus, who's about 50 pounds, which Jasper needs to be let out, so I'm going to walk over there to do that. But Gus is about 80 pounds, or 50 pounds, so he is a medium-sized dog. He would not be a large giant breed. So when I showed you those restraints on him, I could just do them on the floor. They were the same thing that I did with Jasper on the table. I just was able to do them on the floor. So if he were a Great Dane, a Saint Bernard, an Irish Wolfhound, one of those large giant breeds, or even just closer to 60, 70 pounds, you could do his jugular venipuncture sitting, where he's in a sitting position. But I would have him sitting on the floor, and I would have him positioned so his rear end was in the corner of that room. And so the walls, I'm using the walls as a brace so he can't back out of my restraint. And then I'm going to straddle his back, and my knees are going to be up by his shoulders. And that way I can squeeze with my knees around his shoulders to hold him there so he can't just shoot forward. But then I can grab his muzzle and I can lift his head up. So then you have good access to the jugular. I believe there is a YouTube video in that lecture on it, but I'm going to find one and make sure I link it to you guys, send it with this so that you can watch it. But I want you to be able to know that we can get a jugular venipuncture if they're sitting. Sternal is probably the most common on medium to small dogs. I'm more apt to go to the sitting in a corner for a large giant breed. Part of that is once I get a medium size on a table, I'm going to start losing any height advantage at all because I'm shorter. So I have to keep that in mind as well. Our goals of restraint, obviously I'm going to ask you about those, and this kind of leads into that. If I'm not able to keep you safe as the phlebotomist, I'm not able to keep the patient safe, and we're not able to complete the task, then I'm not meeting my goals. Those are my 3 goals. So whenever I'm choosing restraint, I do want to make sure that I am taking into consideration what the phlebotomist would like, but I also have to take into consideration what my strengths and my weaknesses are. So I am not going to have a whole lot of control with a large dog on a table that I'm standing tippy toes or even on a stool to restrain. So if it's not an adjustable table that can go up and down, then I'm probably going to be better off on the floor for me to remain in control of that situation so that you're safe and the patient's safe. So we do have to keep those in mind, but that kind of is a good way to go into, you need to know those 3 goals. You also need to know how much restraint, and kind of the rule of thumb with that is that we use the least amount possible. Now, that is an individual thing. If I take Gus and Jasper into the clinic together, minimal restraint for Gus is going to look a lot different than minimum restraint for Jasper. So I want to use the least amount restraint possible, but still able to accomplish my goals. So my goals were the keeping people safe, keeping the pets safe, the patient safe, and accomplishing my tasks. So with Jasper, that's going to look more like you're probably going to have his muzzle on. We might try some distraction with him depending on what we're doing. And we might even get to a sedation depending on what the issue is that you need to do. We would for sure have traditional restraint with some control on board, and I would have given him, if we don't think we're going to knock him out completely like with dexmedetomidine, then I'm going to probably up his gabapentin, so we're still going to use like a tranquilizer on him to kind of calm him down. So we have that. Gus, on the other hand, he kind of gets scared and just sits there and lets you do whatever you want. So I can draw blood on Gus by myself. I don't need anyone to hold him. He's just going to sit there. Now he might try to leave if you're getting too invasive and he think he can. So you might just need to be there, but you're probably not going to need to hold his head too much. You're just going to kind of be there distracting him and comforting him. So their minimum restraint is going to look very, very different. They're different personalities. So if you remember that video that we saw of Max, the cat that was fired for his behavior, if we know he's coming in, his minimal restraint is the blankets over the carrier and the muzzle. And kind of what we saw in that video was his minimal restraint, which is going to be very different than maybe a kitten that's coming in for the first time, where I would be better off just distracting them with some treats, especially if they're young, they're not fearful, they're not feral kittens. I'm going to be able to do a lot less. So that using the least amount possible is my what I want to do, but that's going to look different for each patient. So that's kind of the synopsis. I was going to lift up, I've got my old tests in here because I wanted to make sure I was looking at those and talking about them with you guys. Because like I said, I'm still making it, but I'm looking at those tests. Sorry, I'm just looking for a restraint here to make sure I didn't forget anything. Because usually my restraint is with my behavior if I couple it with anything. So this is a little bit odd, but it just happened because we lost a week when we started this, and then we lost a testing day because of Good Friday, and so it's just the way it's going to work. And that's okay. It'll be fine. So we talked about restraining goals. Through all the behavior stuff, because we're not going to talk about that a whole lot. I guess one thing that kind of looked in here, and I don't know that I've really said it out loud, I think I've inferred to it, but I just want to make sure. We don't view shock collars as an appropriate restraint tool or a restraint device in the clinic setting. Now, there are some exceptions to when you can use a shock collar, but not really in a medical setting. We shouldn't ever need them in a medical setting. So my exceptions to like a shock collar would be like if you have it in conjunction with an invisible fence, because especially if you're in a place where you can't afford to put a full fence around, or you have an HOA that doesn't let you put a full-fledged fence in, something along those lines. They do have training collars that are shock collars that they're not my favorite to use, but I do think there are some times when you can use them. We have used them for Gus, who is kind of surprised we need to do something like that, but he has a pretty good prey drive. And when we got him, he was already a year old. I got him from school. And so he hadn't really been socialized, and he had not learned kinship identity with farm animals at all. Well, I have miniature donkeys, I have pygmy goats, and we have baby pygmy goats at the moment. We have 4 of them. So he will chase and he'll grab the baby pygmy goats if they get out of their pasture. He can't get into their pasture, but occasionally if they're small enough they can slip through, and we keep finding more holes that we patch up to try to avoid that. But he will, I don't know what his tint is on it, but it is a prey drive. He plays with them, but they're so fragile that it can kill them. So one of the things that we might do, and I do it very rarely, it's when I'm out with him, but we have a collar that you put on it. It looks like the ones for the electric fence or the invisible fence, and it has a remote, and it can shock him, and you can set the not really intensity, the intensity of the shock. And so we don't even have it on shock, we just have it on noise, because the beep scares him. So if he goes up to the fence, or if he's too interested, if he's interested in the goats, we've just gotten to where we push that, and he kind of hightails it away from the goat area. He has like almost 2 acres to run without being in the goats, so he has plenty of room without their area. But I don't use the shock part of it, but I use the sound because it works for him. And that is really, to me, more of a safety issue, because he has to be able to live safely with the goats, and they need to not be killed, and he needs to be able to have the home here, and we do love him, so we want him to stay. So we did that. We brought him in knowing that we were going to have that dynamic, and so we have to be very vigilant with it. So there are some instances where you could use a shock collar, but that would never be in a clinic setting or a hospital setting. That's just not one of those areas we would use that. If I have an animal that is attacking and we're that afraid of, a shock collar is just going to intensify their attack because it's going to make them more fearful. So in those cases, I'm going to use rabies poles. I'm going to use water. I don't normally just spray them with water, but I will if it will break up a fight. You can get the hog sorting boards and put between them and block them. We can use doors, and kind of with a leash, a slip leash, you can wedge them between a wall and a door. That's not the thing I do a lot, but if it's an animal, we had an animal that came in that needed to be euthanized because it had bit, and it met the guidelines if we had to send it in for testing for rabies, and it was very worked up, and it was very it was not acting neurologically correct, which is one of the reasons why we needed it tested. And so we did wedge it between a door and a wall so we could get the back end to sedate it. And then once it was sedated, we let it out, let it loose in its cage until it was out. And then we were able to euthanize in a much calm manner with that. So there are other tools to use besides a shock collar in a clinic and hospital setting. So the shock collars, I guess, would be in my book a tool that you could use in training. It's not my go-to by any ways, and there has to be a certain setup with that. So that's kind of, in case you see that on the test, I've had some tests or questions about that before, and that I've asked if it's one of the restraint devices we might use, and it is not. We've talked about cats having 5 weapons. They have their mouth with their teeth, and then I assume they have 4 paws with claws until I'm proven otherwise with that. So that's kind of my restraint, and then just being able to identify pictures of those restraint tools. I did send out the TPR assessment handout in an email because I did have at least one, I think I had a few more, but at least one person that couldn't open it through TeacherE, so I wanted to make sure everybody could get it. So you should have it there. And on your homework for the obtaining medical history, I asked you what were the normal values for TPR for a dog and a cat. I'm going to have that on the test. You will probably see it on every test from now on for this class because it's super important that you memorize it. And one thing that helps me is to put things together that I can. So a cat and a dog, their normal value for temperature is the same. It's 100 to 102.2. You might see it 102.5 in some resources, and that's the way I was taught it. So if you did put 102.2 or 102.5, I'll accept both of those. The lowest is 100. And then pulse and respiration gets different for them. So you do need to make sure that you have the values for their pulse and respiration as they are different with that. So that's the big thing that I've gotten from physical exam, and that's just because I wanted to have it on at least 3 exams so that you've seen it before you have to have it memorized for really good. We did have in that TPR thing that asked about where do we assess the pulse of a dog and cat, and one of the things that I think that is good to know is that we can use that medial saphenous vessel. We can palpate in that medial saphenous because dogs do have them. They're just under their muscle and a fat layer. They're harder to stick than a cat, but you can feel them, and so you can get a pulse. You can get a pulse a couple ways. I'm just going to bring this. You can get a pulse through your stethoscope. So you have your stethoscope. So a stethoscope would be a tool that we can use to listen or auscultate a heart rate. If I'm getting a pulse, that is typically going to be I'm feeling. And if I am getting a pulse, I typically go with the peripheral pulse. And peripheral means it's away from the torso or the trunk or the main body. So that's going to be in your appendages. So that would be like your legs for our dogs and cats. So our peripheral vein, or actually it's peripheral artery, our peripheral artery that we're going to feel is the medial saphenous artery. There's a medial saphenous vessel or a vein, and there's a medial saphenous artery. It's also called femoral artery. Those are interchangeable words, so I wanted you to know that. And I'm not going to hone too much on that right now, but I want you to start. We're going to talk about it next week. But then knowing our stethoscope, and I will do a little video for you for next week that'll show you the parts of the stethoscope and how it's used. But you have one at school waiting for you when we get back. So that sort of thing. Patient signalment. What are the 5 things that have to be in the signalment? And that's that brags or grabs that I talked about. So your breed, reproductive status, so intact, spayed or neutered. Age, gender, which is the sex, so male or female, and then species, so cat, dog in our case. Those are the basics of a signalment. Other places might have something different. They might include color of the dog or something along those lines. I don't include that, and your book doesn't include that in the basic signalment, because the signalment we're talking about, the basic signalment, is going to be used by specialists if we send things off, or for referral cases where they're not actually seeing the patient. It gives the DVM some information to help with their diagnosis. And so, like we talked about in that lecture, some disease processes are more predominant in certain breeds. They are species specific, some of them. They can be based on age. Gender can play a role. There are some orthopedic issues that are more predominant in females than males. And their reproductive status can play a role, because if they are spayed and neutered, then their testosterone and estrogen levels are lower. So that can actually prevent some of the disease processes. So those are the basics of the signalment, because that's what they need to know to help form a diagnosis, or at least a list of potential diagnoses, which is called a differential list. It's just basically listing all the different possibilities of disease processes, and they make a list and then they start figuring out what tests are going to eliminate the most. And that's kind of how they come up with a treatment or a diagnostic plan, is more the word I'm looking for with that. Blood tests can knock out a lot of things. X-rays might knock something out. So then they have to prioritize with that. So, sorry, Jasper's hearing something. So that would be your basic signalment. See, what else do I have on here? The first thing that you do when you go into an exam room. So kind of when I was doing your attendance quizzes, what I do is I try to take a couple questions that are basic or simple out of your topic that we just covered or was last week. And I try to just ask those to kind of make you think. I try to make them simple. I give you all full credit. Even if you miss it, I've been trying to give you feedback if you miss it so that you see the correct answer. But I'm using those to give you some practice questions. So if I've used it in the attendance quiz, it's probably something I'm going to ask about again, maybe in a different form, though. I had pictures of a lot of different restraint tools up and things like that. But this last one, I asked you what is the first thing that you do when you go into an exam room to get a medical history. And the absolute, some of you said even before you get in, you observe before you approach. And absolutely, you want to observe the patient if you can before you go in. But when I'm talking about starting that interaction between the two, or between me and the client and the patient, the first thing I'm going to do is I'm going to introduce myself and I'm going to state my title. Now, you might then introduce yourself to the dog or the cat, but that isn't going to be in that answer because it depends on the patient. Both of my dogs, you're better off, or you're do fine if you walk in, introduce yourself to me, tell me your title, and then greet them. But if you have a dog that's hiding behind the owner and acrobats behind the chair or hiding, then it might be better to ignore them for a while. So that is going to be dependent on your patient. So the absolute first thing that you do is you introduce yourself, you state your name, and you state your title. Because we need to make it personal by telling them who we are, and then we need to make it very clear on what our position is with the company. So that's kind of the answer to that one. And then the other thing that was on the attendance quiz this week was there are basically 5 things that you should ask every client for every patient, and that's going to be coughing, sneezing, vomiting, diarrhea, and then PUPD is usually put together, but that's your polyuria, polydipsia. I need to ask every client those questions about the presence of those in every single patient. So if I go and take Jasper and Gus in, you're going to ask me those 5 things for both of them because we need to know. It's the bare minimum that we would want to ask. We're going to go into a lot more detail, but those are things that give us a lot of information and they're short. So that's something that will be on your test too, because that's really important. And then we kind of have those sections that was in the PowerPoint in the lecture, and we talk about the background information, how did they obtain the animal, how long have they had them. Those answers give us a lot of information, but I might establish that on the first exam, and then I don't need to ask those questions the second time they come in because we should already have those in file on record. And then we would get into diet history. I'm going to talk about the diet every time, but I might not need to get in as much detail if they are repeat clients and repeat patients. But I do want to make sure that their diet hasn't changed. Because I had you guys do your Jasper assignment, and it's basically on diarrhea for Jasper. Well, lo and behold, this morning there's diarrhea everywhere with him, and he's been struggling with that a little bit. But I had to change his food without the 7 days that I want to give him because I've ordered 3 bags of his normal and they're lost somewhere. So I ended up getting a bag of ID from school. because it's very similar, but it is a little bit different, but it's also very gentle on their GI. But he has irritable bowel syndrome. So it's something that I try very hard not to change his diet. So I kind of expected that, but that's not a normal for him. But I might, as an owner, go, you know what? I know what it's from, and I just don't talk about it. Say we go tomorrow for his vaccines, the diarrhea is gone, and then I just forget about it. So I do want to ask about that. But I also want to ask, so asking about the diarrhea when we start, that could lead into my diet. Because you could ask, so has he had diarrhea? And I can say yes, he had it yesterday. And then I'm going to ask things like, does he get into the trash? Have you changed food? Has he gotten into anything that he shouldn't have? And the changing the food would say, yeah, we did change it because I wasn't able to get my normal food and that sort of thing. So we could go down that, but it is very important to get that diet history. Also, people tend to change food a lot because they think their pet gets bored with it. We get bored with it, but the pet doesn't get bored with it. So, but they tend to think that they want more flavor choices. So they do change it a lot. So that's something we need to keep in mind as well. So diet history, we want to know vaccination history, which is that preventative section. So vaccines, heartworm prevention, flea prevention, tick prevention. I want to know about household issues. There was this section on medication history. What medications are they on? I'm getting to the point where with Jasper, we almost make a list. Well, I do if the kids have to go in and I can't, because I know his medications and the milligrams. But if you look at that patient history, Abby was answering the questions, and she had a good idea what medications he's on, but she didn't know milligrams and things like that. And I wouldn't expect a lot of owners to know that. So a lot of times I tell them to write it down so that they have it with them and they can just show it to us. And then that way we know, especially if they're coming to us because maybe their normal vet is closed and we happened to be open and it was something they felt was urgent, then we would want to maybe make sure we are checking all of that. So medication history, but we had all those little sections in there, and you would need to have a basic idea. Behavior history, that's something that's important, but it's also something that you need to realize that you might not get as in-depth in all of those categories each time they come in, especially if this is a long-term client and long-term patients where we probably have most of this in our records already. So the length of my medical history, or how much I'm gonna obtain, is gonna depend on if they're new or if they're recurrent with that. So that's kind of. I also gave you those words at the end of that PowerPoint for obtaining a medical history. Those words are fair game as well. Just because I really feel like you need to start memorizing those terminology because you're going to have to write them. If an owner tells me that their dog is got really bad breath, then I would probably write they have halitosis, which is one of those words, and halitosis just means bad breath. But using medical terminology in a medical chart makes it look more professional. And if those charts go to a court of law, professionalism is going to be something they're looking at. So if you're not using medical terminology, that can end up going against you in court cases. So you want to make sure that you're using medical terminology. And then also just the anatomy terms. Don't use slang, that sort of thing. So kind of just knowing that, knowing those words, at least being able to have a good idea. And then if I ask, I haven't decided, but if I do ask anything about your medical chart, it's going to be more along the lines of if I give you something like I did with the metronidazole, 250 milligrams PO, BID, X 10 days. Write that out in layman's term, because you're going to have to take those words and write them out on a prescription bottle as directions so that your owners can understand it. And most owners aren't going to understand BID. It kind of cracked me up. I went to my doctor, my human doctor, and we were going through my vitamins and supplements, and I had it listed that what I was on, and I used SID and BID and TID, and the nurse didn't know what those terms meant. She recognized BID, but she didn't recognize SID and TID because they use the computer system so much that they don't use it so much. But we use it in the vet community a lot, so you need to know what those words mean. So, and they wouldn't be, I won't use things that we haven't seen. So PO is by mouth, SID is once a day, BID is twice a day, TID is 3 times a day or every 8 hours. BID could also be every 12 hours, that sort of thing. And then we usually just use the multiplication sign X, and then 10 days or however long we want that to be. So that would be kind of the only thing I would use with that. So I hope this kind of helps. We did talk in the Zoom a little bit today that the 4 that were there, they seemed to feel like the class structure is working pretty well for them. I've tried to state this before, but kind of my goal is that I'm trying to give you all the information in a form that makes it clear, but also allows you to structure it the way that you need to structure it. Because some of you are picking up extra hours, especially if you're working in like a grocery store or something along those lines where they're struggling with keeping things filled. So you might be trying to do that, and I get it. You're trying to, some of you might have parents that are laid off that you're trying to help now a little bit too. I get that. So I was hoping, or you might have children at home that makes doing this at 12:35 every day a little bit difficult. So I was hoping that this would be a format that would allow you guys to structure around what you need, maybe when the kids are napping or when you get home from work or whatever it is. But I am going to continue doing the Zoom chats on Thursdays. I told the girls today that were there that I'm going to give them a little bit of extra credit for being there. I know some of you are at work and can't do that, so I'm trying to think of something else I can do to give you the opportunity to get extra credit too a little bit if you can't be in there for the next time. It's nothing big. It's like just 1 point. It's not going to mean a huge amount, but I do want to motivate some of you to go. It's your time to ask me questions, or I will explain something differently, but it's our only live time we have to talk. So I do want you to use that if at all possible. But I know some of you are working at that, and maybe it's just I'm going to have you respond that you're at work. I don't know. I'm trying to figure out what I'm going to do because I want to make sure I'm fair. But that's kind of what I'm thinking, just so you know. But with the one today, you can do pop quizzes in class, so I'm kind of doing it that way. That's kind of what I got. So if you have any other questions, email me, and that sort of thing. Okay? Thank you.